Hello, everyone, and welcome to the Radiology Cardiothoracic Imaging podcast. My name is Sonny Abbara, and I'm the editor-in-chief of the journal Radiology Cardiothoracic Imaging. The host of our podcast is Praveen Ranganath from Dallas, Texas.
Hey, Dr. Abbara. Hello, everyone.
Hi, Praveen. In this series of podcasts, we will break down recent articles and trending topics from the journal through conversations with the authors, the editors, and experts in the field. For all of you out there interested in cardiothoracic imaging, subscribe and listen to the podcast to keep up to date with recent developments in cardiothoracic imaging.
RSNA 2020 is coming to you. We invite you to take part in this year's all-virtual event, November 29th through December 5th. We're committed to providing the same outstanding programming that you've come to expect from RSNA in a variety of digital formats. All RSNA members get free premium access to RSNA 2020, which includes the following: CME opportunities, on-demand programming, and extended access to meeting content through April 2021. Non-members can register at a special rate until October 1st. Register now at rsna.org/annual-meeting. Hello and welcome back, everyone. Thank you for joining us again on the Radiology Cardiothoracic Imaging podcast. On today's episode, we will be reviewing a recently published article coming out of the Medical University of South Carolina. The title of the article is this: Value of Machine Learning-Based Coronary CT Fractional Flow Reserve Applied to Triple Rule-Out CT Angiography in Acute Chest Pain. The lead author is Dr. Simon Martin, and the senior author is Dr. Joseph Sheff. I will briefly be reviewing the study design, but I strongly encourage our listeners out there to get their hands on this paper and indulge. All right, in summary, this is a single-center retrospective study out of South Carolina that aimed to answer the following question: does a machine learning-based CT-FFR tool add incremental value over traditional interpretation in predicting outcomes for patients who underwent an ED triple rule-out coronary CTA? First, let's do a review of terms. Let's recall that machine learning is a subset within the domain of AI that refers to algorithms that reprogram themselves. Next, CT-FFR. CT-FFR refers to fractional flow reserve calculated from CT data, which helps determine the hemodynamic significance of avascular stenosis. Finally, triple rule-out. A triple rule-out study is a CT offered in the emergency department to patients presenting with nonspecific cardiopulmonary symptoms, kind of like chest pain, that helps rule out 3 life-threatening diagnoses: acute coronary syndrome, pulmonary embolism, and aortic dissection. These CTs typically involve more contrast, more coverage, and therefore more radiation than traditional prospectively triggered coronary CTAs. All right, let's move on to the study itself. Included in the study were 159 patients from South Carolina who had undergone a triple rule-out CTA and had a coronary stenosis on that CTA between 30 and 90% diameter stenosis. These CTs were then analyzed using an AI-based tool to calculate CT-FFR. A positive CT-FFR result was one of 0.80 or less. These patients were followed for 12 months for a composite primary endpoint consisting of the following: coronary revascularization, death, non-fatal myocardial infarction, and hospitalization for unstable angina. What were the results? The primary outcome occurred in 27.5% of patients with a positive CT-FFR and only 10.1% of patients with a negative CT-FFR. So that's 27.5% for a positive and 10.1% for a negative CT-FFR. The authors state that a positive CT-FFR using their tool was a better predictor of the primary outcome with an odds ratio of 3.4 compared to the presence of visually assessed obstructive stenosis alone, which had an odds ratio of 2.2. With all of this in mind, let's move on to our discussions with the author of the study, as well as the author of its accompanying editorial. Hi, everyone. I have with me Dr. Simon Martin from the Medical University of South Carolina. Hi, Dr. Martin. How are you doing?
Good. I'm doing very fine. How are you?
I am great. Hey, thank you for joining us. This study that you are the lead author of is really excellent. Thank you for taking your time to discuss some of the study design and results. Why don't we jump right into some of these questions? Can you help describe what this AI tool was that you used for CT-FFR calculation? And could you help us understand how it differs from the currently commercially available computational fluid dynamics tools out there for CT-FFR?
Thank you very much for this question. And first of all, thank you very much for this interview. Well, the CT-FFR analysis was performed using a dedicated AI-based software prototype that is currently not commercially available. This software is for research purposes only and not for clinical use. Compared with the standard CT-FFR algorithm that is based on computational fluid dynamics, this prototype uses machine learning-based models for the assessment of the functional severity of a lesion. The main difference compared to the commercially available tools for CT-FFR calculation is that this tool is an on-site software that requires user interaction to compute the fractional flow reserve. The anatomy of the coronary arteries and the left ventricular myocardium is derived from the coronary CTA study. And to create a three-dimensional model of the coronary arteries, the lumen is semi-automatically segmented from the images. Moreover, the users need to mark the beginning and the end of each stenosis in the MPR reconstructions. I think this is the most difference to the commercial available, that the user needs to interact for this software prototype.
That's great, Dr. Martin. You know, a lot of us that have used some of those commercially available tools have noticed that it takes a long time to use the study. So how long does it take typically to analyze a study using the tool you used in this particular study?
Well, we found out that the mean duration for the CT-FFR analysis was 70.8 minutes per examination, and the range was 9 to 60 minutes. But we also saw that at the beginning, we needed much more time to do the CT-FFR analysis, and it took up to 20 or 30 minutes or even longer per case. Well, at the end, we were quite faster, and we also did some studies in less than 10 minutes, which was quite fine. I think now if you can do a study, if there are no any specific or big lesions, you can do a study now in 6 to 7 minutes too.
That's significantly different than the potential hours to almost 1 day turnaround for some of the offsite tools. So great. Let's move into the study design itself. Regarding the included patients, does your institution typically do triple rule-out CTAs over just coronary CTAs for patients that present with chest pain to the emergency department?
Well, I think that depends. Like in any other institution, triple rule-out CTA allows for the simultaneous assessment of coronary arteries, the aorta, and the pulmonary arteries in a single diagnostic test. And this approach is most appropriate for patients with a low to intermediate risk for acute coronary syndrome and symptoms that may also be attributed to pulmonary embolism and aortic dissection. And like in most other institutions, it depends also on the patient's clinic and the treating physician.
Perfect. Thank you. Now, I think that approximately 271 patients were eligible, but 95 of those patients were excluded due to image quality not suitable for analysis. Why were so many of those patients excluded? What was it about the images that was insufficient for analysis?
Well, thank you very much for this question. This was one big limitation of our study, that many patients were excluded because of the image quality, and the image quality was not adequate for calculation of CT-FFR. And we think that this might be attributable to the more complex setting of patients with ACP in the ED. But most of the images had step artifacts, motion artifacts, and also most patients could not follow the breathing commands accurately. And I think this was one major issue, that we have had a different patients, different setting and different patients. And we also see in other studies that they only have 5 to 6% rejections of the CT-FFR analysis. And we were almost 30%. But I think we had a different setting, different patients, and I think this was the main issue. We also see this when we send the images to commercially available CT-FFR analysis tools, that we also have a higher rejections rate up to 20%.
Yeah, I was going to say the same thing. A lot of the commercially available tools do have a higher standard in terms of their image quality, while the interpreting clinicians may think they are interpretable. That may not be the case for running subsequent sub-analyses. Let's move to the endpoints and the results of the particular study. The primary endpoint you were investigating was a composite of revascularization and MACE. Now, this endpoint occurred in only 8% of patients, and that was driven primarily by hospitalization for unstable angina. Is that representative of what is seen at other institutions or what is reported in the literature currently?
Well, the primary endpoint was coronary revascularization, not driven by the index triple rule-out CTA, including coronary interventional CABG or MACE, including death, non-fatal myocardial infarction, hospitalization for unstable angina. I do not think that this is representative of what is seen in other institutions. For example, in the PROMISE trial, the primary outcome of a composite of coronary revascularization or MACE occurred in 51%. But this study included patients with stable chest pain. However, we had a different study population with triple rule-out CTA patients with a low to intermediate risk of acute coronary syndrome, and many patients were excluded. I think this might explain the different results.
Perfect. Thank you. That helps clarify the patient population as well as the specific results that you're getting with regard to outcome. Let's now focus on the relationship between the tool that you used for CT-FFR and those outcomes. From what I'm understanding, your study suggests that your AI CT-FFR tool adds specificity and thus adds incremental value in identifying flow-limiting plaque over stenosis grade alone. Could you go into this a little bit further?
Well, I think you can make more confident decisions using CT-FFR. CT-FFR can accurately measure pressure differences across a stenosis and confidently assess its hemodynamic significance. And especially in the ED, I think it's important to have clear results to guide further patient management. And the 3D coronary tree with different colors indicating hemodynamically significant stenosis improves the acceptance and understanding of the results. And this, I think, is most important for the CT-FFR tool in the emergency department.
Excellent. Could you break down the sub-analysis of the correlation between CT-FFR as determined by your tool and downstream testing?
Well, in the subgroup of patients with additional non-invasive cardiac testing, which were 84 patients, there was a higher agreement as to the presence or absence of significant disease with CT-FFR than with coronary triple rule-out CTA, but the difference were not statistically significant. What we saw in our study is that many downstream tests were not concordant with the CT-FFR and the coronary CTA analysis. For example, in 48% of patients, the results of CT-FFR and SPECT did not match. Well, this is remarkable considering prior studies that have demonstrated comparably high diagnostic accuracies of both SPECT and CT-FFR in assessing hemodynamically significant stenosis. In general, SPECT examinations are susceptible to artifacts which may result in false positive findings. And conversely, the limited spatial resolution may result in the underdetection of small subendocardial ischemic lesions, especially in obese patients. In addition, the dependence on the operator for echocardiography image acquisition may result in more subjective interpretation, making accurate object assessment of ischemia more difficult in some cases. And this is, I think, the most important reasons why the results of SPECT and CT-FFR or CTA did not match in all cases.
Excellent. Thank you, Dr. Martin. Yeah, this is, for me, a super interesting combination of machine learning of CT-FFR and triple rule-out ED coronary CTs. all of which are really upcoming in the current field of cardiac CT. So this study is really pushing the boundaries when it comes to that. And I'm excited to see what the next steps are. In fact, what do you think is the most important thing your study brings to the current state of the science?
I think the most important thing is that CT-FFR calculation is also feasible using triple rule out CTA in the ED setting. And I think this is the most important thing, that we can use CT-FFR for triple rule out CTAs.
Yeah, I'm pretty impressed with the turnaround time that you have for exams. After getting expert training on how to use the tool, getting it under an hour in terms of turnaround is pretty impressive. Are you using this CT-FFR tool for other applications beyond ED triple rule out CTs?
Yes, we are also using CT-FFR routinely for coronary CTAs at MUSC, but we use the commercially available tool for clinical use, as this is also FDA approved.
Excellent. Now, what are the next steps for this project? Is there a prospective study on the horizon?
Yes. We are planning a prospective study with CT-FFR evaluation in the ED using the commercially available and FDA-approved software at the Medical University of South Carolina.
Oh, perfect. A head-to-head study almost.
Yes. And also we want the ED physician to take care of the results, or to use the results for further patient management.
Yeah, I'm sure everyone out there is actually really excited to get the next results of your study, but I encourage everyone out there to get their hands on the current study that's published in Radiology Cardiothoracic Imaging. Once again, I'd like to extend my thanks to Dr. Simon Martin, the lead author of this paper. Thank you again. This is an excellent study, and thank you for taking the time to join me on the podcast to discuss it.
Thank you very much.
All right. Hello again, everyone, and welcome back. I have with us Dr. Abdul Ihdayhid, a structural interventional cardiologist who has completed his PhD at Monash Heart in coronary CTA and intercoronary physiology. He's currently doing structural and coronary CT imaging in Vancouver before returning to Australia. Dr. Ihdayhid is the author of the accompanying editorial for Dr. Martin's study, which we have just discussed. Dr. Ihdayhid, could you go through a little bit with us before we jump into the study about the evidence supporting coronary CTA in acute chest pain, more about the limitations of CTA in acute chest pain in the ER, as well as its benefits?
Thanks very much, Praveen, for the introduction and for inviting me on this podcast. So, look, I think in an emergency department setting, patients who present with acute chest pain is one of the most frequent presentations that face EDs and health networks. And from a practical aspect, we want a really quick, accurate, and reliable method that's also cheap to risk stratify that chest pain, and for us to be able to hopefully give the patients that reassurance and get them out the door, quickly, but also identify, the more high-risk patients that need more immediate attention. And as a general rule, CTCA has been demonstrated to be an excellent diagnostic tool, in particular for ruling out disease. There's an excellent negative predictive value. And that's really helpful because the vast majority of chest pain that comes in through the emergency department isn't related to obstructive coronary artery disease. And we can quickly reassure the patient and giving them an anatomical assessment of what's of their coronary arteries, and to tell them that their arteries are normal. But more above that, and that goes beyond just, traditionally we just do risk scores and a troponin and an ECG and we send them home. But it creates an opportunity that if we do a CT and we see mild disease, that we see plaque in the coronary arteries, there's an opportunity for the ED or for the subsequent family physician or cardiologist to instigate medical therapy, because you can see plaque. Although that plaque's not causing chest pain, you're seeing the precursor for something that may potentially cause trouble further on down the track. And then with regards to more significant stenosis, CT is also quite accurate. And a recent meta-analysis in the British Medical Journal demonstrated that using contemporary CT scanners, that CTCA has a high accuracy for detecting coronary stenosis compared to the gold standard of invasive angiography. So, clearly in an ED setting, CT can identify those easily with mild or no disease, and which can be safely discharged. and those with severe stenosis who clearly need further evaluation. But it's the patients with moderate stenosis that form a challenge. Those between 50 to 70%, where it's not mild enough that you could just let them go and reassure them. And it's not absolutely slam dunk severe enough that you'd say this patient absolutely needs a stent and needs to go to the cath lab. And we know from the invasive literature that there's a mismatch between stenosis severity and the physiological or functional significance of a lesion. And the physiological significance is important because we know that if we just decide to stent to narrowing just based on the anatomical narrowing alone or the stenosis severity, then there's no benefit to the patient. But rather, it's the physiological significance by FFR, which pretends benefit or identifies the patients that are most likely to benefit from revascularization. So therefore, in an ED setting, the limitation of CT is that we can't, CT is not very good at identifying which lesions are ischemic or not when they're in that moderate or that sort of the intermediate stenosis. So often these patients need another test, like another stress test. Some of these patients then get admitted to the CCU, maybe with some observation. Some of them will even then get an invasive angiogram and an FFR. All of them are costly. Some of them have side effects and potentially inconvenience to the patient. So it raises the question, can we assess both anatomy and physiology with a single test? And that really forms the basis for CT-FFR techniques.
Let's focus in on CT-FFR specifically there. A lot of us have heard quite a bit of hype around computational fluid dynamics modeling for CT-FFR. Could you talk to us a bit about the evidence for these CFD-based CT-FFR strategies for acute chest pain, as well as how it measures up to invasive FFR?
Well, thanks for your question. And I think there's two aspects to look at it. I think the first part to look at is the underlying, the principles and the validation at the moment for just CT-FFR techniques in general, and then going on to discuss how that relates to the use in an acute chest pain or in an ED setting. And CT-FFR as a whole represents a technique that in general applies the principles of computational fluid dynamics to the geometry of the coronary arteries to simulate a non-invasive fractional flow reserve, or FFR. And it's important to appreciate that the word CT-FFR encompasses many different techniques. And there are techniques that differ with their methodologies and also with the different levels of evidence and also clinical utility, how you practically would use them. In general, the first step for any technique is its diagnostic accuracy. How does it compare to the reference standard? And in this case, that would be invasive FFR. And when we think about applying CT-FFR in the acute chest pain unit, typically the vast majority of these patients are not having an acute myocardial infarction. Otherwise, we'd usually pick that up with the symptoms and ECG. So we feel that it's reasonable to apply the evidence and the validation of CT-FFR in more stable chest pain settings to the acute chest pain population. And that's been the general gist. And across the board, the accuracy for CT-FFR with invasive FFR is good. But there are some caveats to appreciating the evidence. The off-site analysis technique by heart flow, or FFR-CT, which many of the listeners here are probably familiar with, is the most established technique. And there's been 3 multi-center international prospective studies. And the most recent one was the NXT study, and it demonstrated a high diagnostic accuracy of around 87%. More recently, a very well conducted single-center prospective study called the Pacific trial, which I think for people interested in non-invasive imaging has had many excellent sub-studies that have come out of it that has really improved our insight on physiology, on plaque, on CT, and really something that I would highly recommend reading around. So the Pacific study. Anyway, they looked at a study where they compared FFR-CT with SPECT and PET, and they demonstrated that the accuracy of FFR-CT was very high, 88%, with an AUC of 0.94. In particular, on a per-vessel analysis, it was superior to both PET and to SPECT for lesion-specific ischemia using FFR as the reference standard. Now, there's also a lot of interest in workstation techniques. So these are CT-FFR techniques that you don't send off for analysis, that the software is installed on a computer at the workstation, and that the analysis is done by the radiologist or the radiographer or whoever's interpreting the CT. And there's been some interest in this. And the overall, again, their accuracy has also been high. And the techniques in general, they come from mainly CT scan vendors such as Siemens and Canon. There are other people dabbling in the area as well, but most of the literature is around these major vendors. And they've reported a diagnostic accuracy as well in the 80s, between 80 to 86%, which shows promise. But it's important to appreciate and to interpret this data that there are some limitations to it. There are no multi-center prospective studies. These are all retrospective studies. There are some large retrospective studies, but there are no large multi-center prospective studies, which is important. However, the overall diagnostic message for all CT-FFR techniques is consistent in that the main benefit was their positive predictive value and reclassifying CT false positives into true negatives. And so when we go back to our patient in the ED setting who is in that intermediate zone between 50 to 70%, we don't know do we send this patient home? Do we admit them for more evaluation? CT-FFR allows us to reclassify that patient from having what appears to be anatomically significant disease to physiologically maybe more benign disease, and can provide some diagnostic reassurance from a single test. And so as a concept, CT-FFR has benefits for both the patients and the health system.
Yeah, this is excellent. I think from what you're summarizing, CT-FFR brings incremental value to the standard coronary CTA evaluation for our ED patients beyond just the CT data. It's pretty robust in terms of the data that's supporting it, at least for the commercially available software. And there are some smaller studies supporting those that are not the commercially available softwares, but the ones that are available at the workstation.
Yeah.
I think that gets pretty nicely into Dr. Martin's study that was featured in this particular publication of the journal. So let's get into your analysis of this scientific paper. As a reminder for the listeners, this study aims to evaluate a machine learning-based CT-FFR technique in an acute chest pain population. Previously, Dr. Martin and I dissected the results of the study. So between us, let's focus on the broader context of CT-FFR science, talking about the methodology in this study specifically. So could you talk to us about the CT exam preparation that was used in the study and how it compares to some of the major trials that have been done for CT-FFR?
So look, thanks for that question. And I think the authors are to be congratulated on their work and getting it published and really trying to think outside the box and how we can apply these techniques to sort of non-conventional settings outside of just elective stable chest pain. And so, however, there are inherent limitations in retrospective analysis, and in that you couldn't upfront apply the most contemporary and the most ideal acquisition techniques to do your analysis. So, with that in mind, one of the limitations in this study was that the acquisition protocol had minimal nitroglycerin and beta blockade usage, and we know that the field of CT, it is clear and really evident now that good quality, accurate and reliable CT-FFR starts with good quality CTA acquisition. And, the first question that anyone will ask when you question the accuracy of a CT-FFR result is what's the quality of the CTA acquisition? Because that forms the basis of the analysis. And we can talk a bit more about that later. And we know that the CT quality in general, the absence of beta blocker to control heart rate, it, impacts quality, in particularly because it causes motion artifact. And secondly, the absence of GTN. And for those who've been reading CTs for a long time, when GTN was somewhat voluntary and now it's, one spray and now many centers are doing 2 spray, people have seen that clearly the visualization of the lumen and their ability to read stenosis in a more accurate manner with appropriate nitroglycerin, i.e. the vessels appear larger, is significantly improved with nitroglycerin. So why is this important for CT-FFR? Because the first step of analysis for CT-FFR is generating an accurate geometry of the coronary artery. Your analysis is only as good as that geometry. If your geometry is inaccurate, well, then you're not simulating something that's real. So to simulate that patient-specific geometry, to generate patient-specific non-invasive FFR, you need an accurate geometry. And the key to that accurate geometry is good quality CTA. And we know there's been numerous studies now that have shown that if in the absence of beta block and the absence of GTN, it impacts the accuracy and the feasibility of CT-FFR. So I think it's important to put this data and also this methodology into the context of other studies. And the most notable study of using a CT-FFR technique in the ED setting was reported by Kavitha Chinianen and Gilbert Rath's group from Beaumont Health in JACC Imaging this year, and where they used the heart flow FFR CT technique in an observational study of 550 patients. In this study, the authors demonstrated that all these patients received beta blockade, aiming for adequate heart rate control, and all received nitroglycerin. And they demonstrated that integrating FFR-CT into the diagnostic pathway of patients with acute chest pain was feasible, with no difference in MACE compared to CTCA. Furthermore, a negative FFR-CT was associated with a lower incidence of obstructive CAD compared to a positive. And one of the questions that people often raise is, well, what's the turnaround time in an ED setting? And in the paper, they nicely demonstrate that over time, the turnaround time now for sort of urgent or more acute cases was around 2 hours. Importantly, one of the initial issues around the CT-FFR literature when it first started was the feasibility. Initially, rejection rates from initial studies were between 10 to 20%. But in more contemporary studies, we've seen that in the advanced registry for FFR-CT, the rejection rate from HeartFlow is around 3%. And in this study by Gilbert Raff's group in the ED setting, the rejection rate is 1.8%, and that's excellent. And really, it's a testament to the I think the culture of cardiac CT, and that this that I think as a community, cardiac CT is really, there's been a lot more emphasis on really good quality and acquisition with adequate heart rate control and adequate nitroglycerin. So I think that's an important point to highlight.
Do you personally use nitroglycerin and beta blockade for your coronary CTAs? And if so, do you use diastolic phase imaging, systolic phase imaging?
Yeah, look, thanks for the question. Look, where we come from at Monash, we're very, very meticulous about beta blockade. We use a combination of actually beta blockers and ivabradine, which I think is available in the US. We ideally aim for heart rates less than 60. And certainly heart rates above 65, we'll try to be aggressive with lowering that down even more with IV beta blockade. All patients would receive nitroglycerin. We think that that's a really important step for good quality, just CTA read. We're an academic center for CT-FFR. We've done studies with both workstation techniques and with FFR-CT. And I think that by doing good quality CT acquisition has help facilitate our CT-FFR research program.
Yeah, completely agree. And the testament to that, as you're mentioning, is the reducing very, very small rejection rates for at least the commercially available CT-FFR study in using our CTA data that we've been contributing. One thing to note is, at least with Dr. Martin and his colleagues' machine learning-based technique for CT-FFR, there was a relatively high rejection rate in terms of the included patients versus those that were actually eligible. It's about 95 of the almost 270 patients were excluded, many of which due to non-suitable image quality. So one wonders if it's also related to the software that's being used beyond just the quality of the images themselves.
Look, that's a good point. I guess it'd be interesting to tease out what are those reasons for rejection. Were they just by the physician saying, I don't want to put this study into this retrospective analysis because I think the quality is not too good? Or as you say, is it the software saying, I can't analyze this? I do think that raises a very interesting point. And I think as somebody who's done a bit of research in workstation techniques and coming from a center that's also interested in it. And I think one of the challenges is that, how do you install quality control at an on-site workstation level? Because technically you could have a feasibility of 100% when you're on the site doing it. And because, with the FFR-CT technique, you send it essentially to a call lab and the call lab makes a decision whether it's feasible or not. And so I think there probably needs to be more granularity at an academic level about what are the factors that should preclude us from doing a CT-FFR analysis on a workstation technique, and how do we embed that into software algorithms that would then provide some safety net that actually, that maybe you should interpret this analysis with caution because the quality here isn't so good. So I think I hope that point comes across, but I think that's an important step for the field to still mature into.
So with regards to quality control and even interpretation of the CT-FFR analysis, Can you speak more on where this analysis should be performed or how it should be interpreted relative to an anatomic model that we generate or that the software generates? And we can put that into the context of how Dr. Martin and his colleagues created their model and applied their analysis.
Look, thank you for that. This is something it's a really interesting point, because when we look at, one of the challenges is that where do we measure the CT-FFR? For people who've done research in the area and have done diagnostic performance studies, it's easy. Patient goes to the cath lab, you put a wire down the artery, you record where the wire is in the artery. That's where we've measured the pressure and the flow. And then the patient has a CT, and then we match up where on the anatomical model where the wire was, and we put our cursor there on the CT-FFR model, and we've done what we call co-registration. In the real world, we don't have a wire to tell us where to measure. And so some of the initial clinical utility studies, such as Platform and that used FFR CT in a real world setting, took the most distal aspect, or the nadir. And we do know, though, that there is sometimes that you can get pressure loss in the distal vessel in the absence of stenosis, i.e. you can have a positive FFR CT very distally, and that can sometimes affect the specificity of the test and potentially or maybe lead to inappropriate referral, or just, so to temper that, there's then been a thought, well, why don't we measure it just distal to the lesion, like 20 to 30 millimeters distal to the lesion? And that gives us a more accurate or a more granular assessment of that lesion-specific physiology. What that lesion, how is that impacting on the flow? So when I measure 20 to 30 millimeters distal, that's that, I'm getting a better insight into the impact of that narrowing that I'm worried about. Do I need to stent it or not? And so there's that. However, a potential limitation to that technique is that you're then missing out or not interpreting everything that else goes distal to it. There could be another lesion, i.e. serial lesions, which would be important to consider. There could be diffuse disease, which would, the patients who have a really distal positive FFR CT, they could have, there could be just diffuse disease that needs to be taken into consideration. So, it's a balance. So I think one of the, there's a few strategies being put forward. And I think one of the thoughts is that we consider, we integrate both. That you take the most distal value, and then this is what we do in the cath lab. We do a pullback of the wire. So if we evaluate what the physiology is, what's the physiological profile of that entire vessel, and we then interpret the artery in that context. Well, okay, is the pressure drop really focal or is it diffuse? If it's focal, what's that pressure drop? Is it a large pressure drop across the narrowing? Maybe those patients with really large pressure drops would benefit. One of the areas that we're interested in also is looking at integrating other biomarkers from CT to help augment the decision-making process. And one of those is this CT-derived myocardium at risk. And if you think about it now, for example, so the CT myocardium at risk could potentially guide and provide more clinical context to the value that you're looking at. So I'll give you by way of example. For people who've looked at, used FFR CT before, maybe the patient didn't have a significant, it was an mild stenosis, but your very distal vessel was positive. Say it was 0.78. But where did it become positive? Where did it become less than 0.8? Right at the tip. So if we just looked at the myocardial mass that is distal to where it starts to become positive, i.e. less than 0.8, and we can see there, the myocardial mass in this setting is very small. So therefore, therefore in that setting, we could probably give reassurance to the clinician that's probably not that clinically relevant. And so there was a recent paper that was published in Heart by Nico Paal's group in Belgium, where they validated a method to quantify fractional myocardial mass. And that opens up the door to potentially integrating FFR CT with fractional myocardial mass. So at any point on the FFR CT model that you put your dot, so you say the dot there is 0.75, that 0.75 is associated with 20% potentially myocardium at risk. So that, that might help augment how we interpret these values. So therefore, we're looking at not just the depth of ischemia or depth of physiology, but also its breadth. And if we see, if the breadth is very narrow, i.e. there's not a lot of myocardium at risk, but the FFR CT is positive, maybe this patient doesn't need revascularization. Maybe they just need aggressive medical therapy. And that still needs to be teased out. But I think that the interpretation, unfortunately, and I'm sorry I'm going on a bit about this, but unfortunately, as humans, we like binary cutoffs. We like, hey, just tell me what to do. Just lesson 0.8. There's only one way, isn't it? Heal with steel. Give me a stent. But in reality, medicine is nuanced, and there are gray zones. And I think that certainly in values around the diagnostic cutoff, we should be thinking about other metrics. What's going? What about the plaque? What about the myocardial at risk? What about the biomechanics? What about the clinical symptoms, the story? So I think that as clinicians, I think that CT and CT-FFR are really sophisticated tools, and but they also need sometimes a degree of thought in the way that we interpret it.
Dr. Ihdayhid, this is perfect. That's a great explanation as to the nuance that goes into CT-FFR acquisition and interpretation. Let's switch gears a little bit. Can you talk to me about your thoughts on the author's sub-analysis comparing their CT-FFR tool with other modalities in non-invasive stress testing?
Thank you. I think, I think it's challenging to compare the clinical utility of these tests in a retrospective manner without sort of prospectively defining how they were, acquired and interpreted. But I think in general, I do think in general it's important for workstation techniques to be compared to other non-invasive imaging modalities. However, it's not always a direct comparison. A fractional flow reserve is a physiological assessment of the epicardial coronary arteries, which is related to the microvasculature. But perfusion-based studies, they're seeing both epicardial flow and microvascular flow. And so you could have patients who have a normal FFR, but an abnormal perfusion. And that could be because they have microvascular dysfunction, or they have, left ventricular hypertrophy, or whatever that is. So, sometimes that has to be taken into consideration when interpreting these results using FFR as the reference standard. That said, for FFR-CT, there's quite a decent body of evidence comparing it to other modalities. I think it would be important for workstation techniques to go down that path as well. And certainly I think in a North American context, SPECT, I think it would be important to look at that and protect, and also PET, which is, a really great tool for getting absolute coronary blood flow quantification.
What's typically used for functional imaging where you have practiced before, both in Australia and in Canada?
So in the Australian context, the most common modality, if we saw an intermediate lesion, that lesion where we need to do something else, it's not quite medical management, it's not quite definitely PCI, is a stress echocardiogram. So that's often how patients get restratified. The other common modality that I've seen used around and also here is myocardial perfusion scans, or what you guys call SPECT as well. However, we've found that it can certainly SPECT, and we have sometimes some false positives, some false negatives, and it's not. We found that a challenging tool sometimes to use as the arbitrator whether someone should go to the cath lab or not. And I think it makes more sense to me as an interventionalist that the tool that I'm going to use to arbitrate in the cath lab, if I can mimic that non-invasively, that's the kind of tool that I'd like to use. I.e., like a non-invasive FFR would make sense to me.
Perfect. With regards to the featured study from Dr. Martin and colleagues, what do you think is the biggest advance to the science that is brought?
So I think one of the really interesting things is the use of machine learning and a machine learning-based algorithm. And, I think that certainly if we go back to the start and if we go back to how workstation techniques came about, initially there was this thought, well, instead of sending it, that more three-dimensional based techniques, require a lot of intense computation and maybe even need, parallel supercomputing. Well, why don't we simplify the computational fluid dynamic analysis and simplify the anatomical model or the coronary geometry? Instead of being in a three-dimensional space, let's simplify it to a two-dimensional space, so the computational fluid dynamics analysis is a little bit more simplified with the primary goal of reducing analysis time. And so initially, these workstation-based techniques had analysis times of between 20 to 30 minutes. I mean, so, you hit analyze, you come back after 30 minutes, you get a result.
It's pretty fast.
So, I mean, it's fast when you look at it in the absolute value. However, in a clinical setting, there's still an appeal to go even faster. I mean, that's just the nature of cardiologists. We want to go as fast as we can. And so what what machine learning does, the machine learning consortium, in a paper that was published in CERC Imaging, they trained the machine learning algorithm based on anatomical features to try and predict FFR, and they were able to validate this algorithm from generating synthetic models, and in a very nice paper, which is worth having a look at. And so they were now able to, because it's all done machine learning and it's pattern recognition, there's no CFD now. And as a result, the analysis time now goes from 30 minutes to 2 seconds. So it's essentially, it's real time. You click a button and you get the results. And so I think that's very promising. And certainly it's attractive from a time perspective, but there are some caveats and some potential limitations that it's important in the field of machine learning. When we think about machine learning, we have to always think about what was the data set that it trained from, and the data set, it's still relatively small, like in the bigger picture. So there are some important caveats, however, to appreciate about machine learning in general. And I think it's important to recognize that machine learning the performance of machine learning is very much dependent on the quality of the data that it trained on. And so it's important that machine learning algorithms are validated on really diverse and large data sets. And ideally, this field requires a large prospective international multi-center study to really test it out in a real world setting with different scanners, with different acquisition techniques. How does it hold? And seeing the variety of, yes, it's been tested on lots of synthetic models, but now seeing the variety of human anatomy and calcification, and there was actually a paper on calcification and showed that its performance was still good. But I think that's an important tool. The second thing is that when we think about it, how does it get better? Again, because I think if there's any further modifications to the underlying CFD engine, which we shouldn't just stop there. There may be some more further modifications. We may need to retrain the machine learning algorithm. But I think that's only half the story. And I think as somebody, and I spent a lot of my PhD drawing circles and segmenting a coronary lumen, which I wouldn't recommend. I know I learned a lot from it, but it's slow and it's painful. Anyone who's done a PhD knows that.
No, for sure.
It's slow and painful. But that's only half the story. The other half of the story is the coronary luminal segmentation. And I think that's an important thing to consider when we think about the clinical utility and where workstation techniques can practically fit into a real world setting. Then when we look at the machine learning paper and we look at the papers that we've wrote on our workstation techniques, the manual segmentation time was 60 minutes. Was around 45 to 60 minutes. So although the analysis to hit click button, get the result was 2 seconds, to generate the accurate anatomical model for this study, where they were really vested to get really accurate results, was 45 to 60 minutes. So the take-home message really to the broader audience is that if you want to achieve similar results, you need to pay the same kind of attention and detail to your segmentation. So I think that that's still far too long in a real-world setting. How do you say that to a site? Do you say, well, look, you can spend an hour segmenting it. You'll have to train someone how to do it. And as one of my mentors, Dr. Leipzig would say, there's no accuracy without reproducibility. And so, do you just train one person? Do you train multiple people? And how do you get consistent results? And whereas if you could send it off-site and get a result within 2 hours. So I think the sell for workstation techniques, that the time has to significantly reduce for luminal segmentation. But the question is, how do we do that? Because as I was, and I think I alluded to in the editorial, is that we don't have as yet standardized techniques. What typically happens is that all these software algorithms have built-in segmentation algorithms. So you put the CT machine through the software, it gives you a lumen segmentation. It gives you a coronary geometry. Now, in a busy practice, you're like, well, I'll trust the machine, click, just keep analyzing. Now, we know that if you don't make modifications, we know that these algorithms are limited around stenosis and around calcium. And if you just accept things as they are, it's going to impact your accuracy. We recently published a study where we showed, well, look, okay, let's just say all you did was focus on the narrowing and the calcium versus being very meticulous and spending up to 40 minutes on a patient, and we found that if you're meticulous, you improve your results and you improve your accuracy and precision and reproducibility. But it increases your analysis time by fourfold. So, I think the field certainly needs to consider whether machine learning can be applied to coronary luminal segmentation. I think that would be a really important step forward for translating these techniques into clinical practice.
Excellent. Dr. Ihdayhid, I feel like we've touched on a tremendous amount of topics, and we could continue this discussion on to the end of time. What do you think then should be the next step in improving CT-FFR, though? What do you envision is the next big thing coming in the field?
Look, I think if we look at where the evidence is going, and I think that certainly with the FFR CT literature, there's really now quite a good body of evidence now that has demonstrated its diagnostic performance. There's now been several studies that looked at its clinical utility and prognostic value. But I think overall for the entire field, and I think one of the things that I'm really excited about is therapeutic guidance. How can we use CT and FFR CT to guide our decision of how we treat a patient in the cath lab, or even how we treat patients with medical therapy? And certainly one of the areas that's you may have seen is like this concept of virtual stenting, or the PCI or PCI planning. So, i.e., that we know that from the literature that up to a third of patients, when they go to the cath lab and they get a stent, even if they get a stent using the most contemporary techniques, i.e., using physiology, using FFR to guide the stent in the cath lab, still 30% of patients will walk out and they haven't got a good physiological result, i.e., they're still left with either a low normal FFR or still with residual ischemia. And that portends worse outcomes for patients. And it's challenging in the cath lab. You've just spent 35, 40 minutes doing a stent and you've done the wire. It's uncomfortable for the patient to do the adenosine. So there's a lot of inertia to put the wire down again and remeasure FFR. So the concept is, well, can we do that planning offline? Can we use the CT model where we've now modeled FFR, and can we model the effects of a stent on that stenosis to predict what the physiological gain from that PCI would be? And there's been several studies now published. Von Cooney's group initially published it in 2014. A group from the UK published another validation in Circulation Interventions last year. And certainly, as a method to try and predict the physiological benefit from revascularization, it shows promise. And there's a great study that I've had the privilege to be part of with my mentor and supervisor, Brian Coe from Monash, under the supervision of Carlos Colette and the team in Belgium, the P3 study, and Dr. Leipzig as well. And this is a study looking at, how we would, evaluating in a very, very detailed manner the ability of the planner to predict the physiological benefit post PCI. So if you can envision a situation where you've got a patient with an LAD, you've got a 70% narrowing in the proximal vessel, and you've got a 50% narrowing in the mid vessel. Now, but they're separated quite a bit apart. So you could make the argument, well, maybe I should treat both of them. Maybe I treat one of them. I don't know. And so we know that now there's a recent study that came out that the length of stent that you deploy is also a predictor for MACE. So ideally, if you can minimize the length of metal that you put in the patient's heart, that's also a better thing for the patient. So if you could use your virtual stenting techniques or the PCI planner to say, look, if I treat just the top lesion, am I going to achieve an excellent physiological result? And if that's the case, well, then I can be confident, hopefully in the cath lab, that I can just leave the mid lesion alone. If when I apply a virtual stent, there's still an abnormal physiology in the vessel, then it gives me confidence that I should probably just upfront treat both lesions. I'll save time, maybe radiation, discomfort for the patient. So I think that's a really, that is a really exciting field to pursue. But there's another aspect, and I think, and so that's for sort of PCI. But the other aspect is how we improve and become more sophisticated in our risk stratification. We've gone from taking population level risk scores, which now all of us agree, are limited, and we've now added on calcium scores, which have provided some more granularity to the ability to provide risk stratification. But clearly the risk of plaque rupture goes beyond just one metric, and likely, and physiology, provides also a lot of insights into plaque and plaque biology and biomechanics beyond just ischemia alone. And, we know that there's been several studies that were published in JACC Imaging and JACC Intervention recently with some nice editorials, which highlighted that FFR is correlated to high-risk plaque, i.e. that the more high-risk plaques that you had, the more likely that you were, or the more low attenuation plaque you had, the more likely that you were to have an abnormal FFR. And that, we think biologically that makes sense. The more inflammatory plaque that you have, the more likely that you're going to have impaired vascular health and impaired ability to vasodilate, or therefore impacting your FFR. There's been we also know from excellent work from Preeta Stone and Habib Samadi in the invasive literature that plaque biomechanics make a difference. That the shear stress across a plaque is a strong risk factor in plaques that progress and plaques that rupture. But to do shear stress invasively, again, is something that you would only give to a PhD student that you don't like. It's really like invasive work and really time consuming. So the question is, well, can we derive shear stress non-invasively? And in a really nice study in the Emerald study, again led by Bonpong Koo from South Korea, they looked at deriving shear stress from the computational modeling of FFR-CT, and they found that there's incremental value of predicting patients that had a MACE by integrating shear stress with plaque and FFR-CT. But there's another important point, and I think this is to me where we don't need to do really complex things to try and get shear stress. We know that the pressure loss across a lesion likely is a surrogate for that shear stress. So, i.e. the delta. So if you have a really sharp pressure loss across a lesion, even if that lesion is not functionally significant, the Emerald study would suggest that correlates well with shear stress. So to put this together, I guess to summarize, is that from a simple test, from a CTA, which gives you anatomy and gives you, quantitative and qualitative plaque, with overlaid with a physiological simulation to give you both, lesion-specific ischemia or physiology, to give you delta FFR, which is a measure of lesion-specific physiology, but also biomechanics, I think allows us to probably do, and now with PCAT, with pericoronary inflammation, there is a role here for probably machine learning and artificial intelligence to integrate all these factors to help provide a more sophisticated analysis of risk for our patients, to provide more personalized assessment of risk and hopefully more personalized treatments.
Dr. Ihdayhid, thank you so much for your evaluation, your analysis, your expertise. We really appreciate your time on the podcast, and I really appreciate you providing this editorial, not only of this specific study that's featured, but of the field of CT-FFR altogether. It has been excellent. Thank you so much for your time.
Thanks so much, Praveen. I really enjoyed that. Thank you.
Of course. And I encourage all of our listeners out there to grab a hold of this editorial by Dr. Ihdayhid and Dr. Zekry. It's available in the June issue of Radiology, Cardiothoracic Imaging. All right. To all our listeners out there, thank you again so much for tuning in. Once again, the scientific paper by Dr. Martin and colleagues, as well as its accompanying editorial by Dr. Ihdayhid and Dr. Zekry, are both available in the June edition of the Radiology Cardiothoracic Imaging Journal. Please, if you like what you heard, rate, review, and subscribe to the podcast. My name is Praveen Ranganath. Thank you again. Goodbye.